Our last topic of this chapter is obsessive compulsive disorder and disorders that appear to be related to obsessive compulsive disorder. Of course, obsessive compulsive disorder is defined by obsessions and compulsions, which I will define shortly. But there do appear to be a spectrum of obsessive compulsive disorders, with some items clearly on the spectrum and others more distantly related. Obsessive compulsive disorder is characterized by compulsions, which are behaviors, but behaviors that are often very ritualistic. If they are not performed in a very precise way, they are not effective. Obsessions are thoughts, but they often feel like the thoughts are coming out of nowhere. They are ego dystonic, that is, they feel like symptoms and the individual does not want to experience the obsessions. And they're often ego alien. They feel not like the person's thoughts, but somehow thoughts that are somehow forced on them. Now, most patients with OCD are well aware that their obsessions and their compulsions are unreasonable. Sometimes they're able to hide it, sometimes they're not able to hide it. But they often are embarrassed by the symptoms. It is not uncommon for people, sometimes with pretty severe obsessive compulsive disorder, to attempt to hide those symptoms from everyone except their closest friends. What are typical obsessions and typical compulsions? Obsessions often revolve around dirt and germs, the idea that one's actions may hurt another person, feeling like you've done something or haven't done something that you're supposed to have done, and often a sense that you might have done something bad but were not sure. The compulsions sometimes fit the obsession. So, for example, if you're obsessing about dirt and germs, cleaning or washing is a perfectly reasonable compulsion, except that it's usually carried to an extreme. Other compulsions have no relationship to the obsessive thoughts. For example, counting rituals are common in OCD. So the individual might have an obsessive thought and then they need to count to a certain number. And they have to count exactly right. So they may have to count over and over and over again until it feels correct. Some of the compulsions, like checking to make sure that you didn't forget something, makes sense. Ordering is occasionally found as a compulsion, but it's more commonly found in obsessive compulsive personality disorder, which we'll be talking about later in the course. A lot of these compulsions are ritualistic. Rituals seem to be important to human beings. When someone dies, we have a lot of rituals associated with the funeral and the wake. And it's one of the ways in which we comfort ourselves. And the rituals found in OCD may, in fact, at times, serve that particular purpose. Now, when I was describing the symptoms in the previous slide, you probably were saying, well, I do that. And that doesn't seem terribly crazy to me. Well, chances are you do, but not at the level that you typically find in OCD. So, for example, you might worry about whether you locked the house before you left, and you go back and check. It's not uncommon in OCD for that checking to last for 40 or 50 minutes, where the individual literally checks hundreds of times and still is not sure that the door is locked properly. You might, for example, be concerned that you hurt someone. Perhaps you felt a bump while you were driving and wondered if you hit someone, a person, a dog, a young child. But it's not uncommon in OCD for those feelings to lead to the individual spending hours driving all around because they're afraid the person crawled off into a bush or something and died. and never being sure that they didn't hit someone. If you're concerned with contamination, you would wash your hands. As I am recording this, we are in the middle of a COVID-19 pandemic, and people are washing their hands on a regular basis, much more regularly than they once did. In OCD, that hand washing can become so extreme, both in terms of how long it's done and how strong the soaps are, that people will wash their hands until their skin falls off. Now, if you think about it, that's counterintuitive if you're trying to avoid contamination and possible infection, because our best defense against infection is not washing our hands, it's maintaining our skin. We typically don't get infections on our skin. We get infections where the skin has been broken with a cut or something of that sort. If you wash your hands to the point that the skin is falling off, you're going to be subject to lots of infections. This is going to sound familiar because it's been true of all of the anxiety disorders. There are many factors that contribute to OCD. A generalized biological vulnerability that appears to be polygenic, several genes contributing to it, and in the case of OCD, moderately strong, about as strong as panic disorder, much stronger than phobias, for example. There's also a specific psychological vulnerability. Often there are early life experiences that seem to reinforce obsessive behavior. There's also a tendency for people with OCD to have a sense that things, including their own thoughts, can be dangerous and completely unacceptable. Often you see what is called thought-action fusion. Okay, we've all had the sense that sometimes our thoughts might lead to something actually happening. So we think about someone dying and we worry, oh God, what if they actually do? Well, in OCD, that thought can be very powerful and very believable. And as a consequence, every time you have a bad thought, you worry terribly that you've caused something in the world, something serious to happen. Now, with OCD, the compulsion sometimes will produce momentary distraction, but the distraction cannot be maintained for very long. So what happens with OCD is the symptoms appear. Occasionally the individual can back off from the symptoms, but they seem to come right back, sometimes with a vengeance. There are two primary therapies for OCD and a secondary therapy that is used very infrequently. Psychologically, the only treatment that has shown itself to be effective is a behavioral treatment called exposure with response prevention. If people with OCD, for example, are concerned with contamination, what you do is you make those obsessive thoughts very powerful by having them get down on their knees and rub their hands in the dirt, so they're clearly contaminated. And then you try to get them to not do the compulsion that they feel they have to do. That's the response prevention. Now, the therapist never prevents the response. You want the individual with OCD to control their own behavior. Sometimes they'll be able to do it, sometimes they simply can't prevent them. But what they're doing is an exposure-based treatment without the compulsions to see that the anxiety will go down even without doing the compulsions. What the compulsions do is remove the anxiety, at least momentarily, and give the impression that the only way they can control the anxiety is with the compulsions. Traditional psychotherapies, talk-based psychotherapies, even cognitive behavioral psychotherapy, tends not to be terribly effective compared to exposure with response prevention. Biologically, the primary treatment is medication, specifically SSRIs, selective serotonin reuptake inhibitors. What's important to know is that the dosage for treating OCD is much higher than for treating things like depression. If you take Prozac, which is the original SSRI, and you have depression, you probably will take 1 pill a day, 20 milligrams. If you have OCD, you're likely to take between 4 and 6 pills a day. Much, much higher dose. A treatment that has been studied but not used very often is psychosurgery, specifically a cingulotomy. Specifically, you are deliberately damaging the cingular gyrus, which seems to be important in OCD. This is much more sophisticated than the lobotomies that were done in the 40s and 50s. But it's an irreversible process and therefore tends not to be used very often. I mentioned that there are several OCD-like disorders. One is body dysmorphic disorder, often called BDD for short. In body dysmorphic disorder, you have an obsession, but the obsession is about some flaw in your body. Perhaps your nose is not quite right, or you feel like your face is deformed. We know that genes contribute, and they seem to overlap some of the genes for OCD. Curiously, childhood neglect and abuse is common in these individuals, and we don't know if that represents a part of the causal factor or might be a response to early symptoms associated with body dysmorphic disorder. Also, there are cultures that show high rates of body dysmorphic disorder and other cultures that show very low rates. And it doesn't seem to be based on genes, so we suspect that there are psychological mechanisms that contribute. What convinces us, besides the overlap in genetics, that this is probably a variation of OCD, is the same treatments that are effective with OCD tend also to be effective with body dysmorphic disorder. Another OCD-like disorder is called hoarding disorder. They have television shows now about hoarding disorder. Here you have individuals that are collecting items that they simply cannot discard. They experience overwhelming anxiety at even the thought of throwing them out or giving them away. Again, genes seem to play a role, and there seems to be some overlap with the genes associated with OCD. Let me emphasize again, we do not have the technology to know which genes are involved at this point, but we do have the technology of being able to tell whether there's some overlap in genes between various disorders. Cognitive behavioral therapy seems to be most effective here, which suggests that hoarding disorder may be different from OCD. Cognitive behavioral therapy is not particularly effective with OCD. You need exposure with response prevention. But with hoarding disorder, it does seem to show promise. Another disorder that shows compulsive behavior is called trichotillomania. It's a hair-pulling disorder. Sometimes the person will pull out large amounts of their hair so that you can find bald spots on their head. Now, when we're anxious, we tend to play with our hair. Now, I don't have a lot of hair. It's very common for people to run their hands through their hair. Usually, they run their hands through their hair on the side of their head. Occasionally, they might pull out a hair, but not so much that it would show. With trichotillomania, sometimes they will pull out hair from the top of their head. Sometimes they will pull out eyelashes or eyebrows until there are no eyelashes or eyebrows. And occasionally they will pull out hair that is not normally visible unless you happen to regularly visit a nudist colony. So they might pull out pubic hair. Now, obviously, pulling out hair is uncomfortable. Pubic hair particularly uncomfortable because there's a lot of nerve endings in that area. But it seems to reduce the anxiety for individuals. So it has this obsessive compulsive behavior, but without a lot of obsessions. It's kind of a compulsive behavior that reduces anxiety. What's interesting here is SSRIs clearly do not work. And so even though there may be some shared genetics with OCD, apparently the biological treatment typically that works with OCD doesn't work. There is a class of drugs, clomipramine, that does show some moderate effectiveness. And generally, the treatment is a behavioral treatment called habit reversal therapy. It's similar to exposure with response prevention, but the focus is more on the response prevention and substituting other behaviors instead. A behavior that on the surface looks similar is called excoriation disorder, which is skin picking. Now, if you've ever hurt yourself and had a scab as it was healing, you often have the sense that you want to pick the scab here. What happens in excoriation disorder is you're picking usually at healthy skin, and you can do it to the point that you peel off the skin and it starts to bleed. And not surprisingly, if you do this often enough, you get scarring and, of course, a huge risk of infection because you're breaking the surface of the skin. Genes may play a role, we're not sure. What's interesting is SSRIs work here. Now, they're not great, but they're better than nothing. They show some treatment effectiveness. And with trichotillomania, they did not work. So even though on the surface they look like they're variations of the same theme, they appear not to be. Habit reversal therapy works, and giving people alternative behaviors seems to be effective as well. In this section on OCD-related behaviors or disorders, there's a recognition that we can get OCD-like symptoms from other sources. Some medications can promote this behavior. And there are certain medical conditions where it's common to see this kind of obsessive-compulsive or obsessive-compulsive-like behavior. But there's also a recognition that sometimes this develops and it's not clear where it came from. So we acknowledge that we can identify OCD behavior that might not fit any of the disorders that we've talked about in this section. So in this chapter, we covered a number of anxiety disorders. All of them share anxiety, but the nature of the symptoms and the disruption that they cause is often quite different. What's clear is there's no single cause for any of the anxiety disorders that we're talking about. And it appears that there are multiple ways in which such a disorder might develop. Treatments usually involve medications, typically SSRIs, and anti-anxiety drugs, like Xanax, for example. Most often, cognitive behavioral therapy is the optimal treatment, although there are variations in that therapy depending upon the nature of the anxiety disorder. Also covered in this chapter is obsessive-compulsive disorder and a variety of disorders that either appear to be similar to obsessive-compulsive disorder or have some evidence that they overlap, perhaps with related genetic contributions. OCD is best treated behaviorally with something called exposure with response prevention and with medications in high doses, such as the SSRIs. Some of the OCD-like disorders respond to similar treatments, but others do not.